as the course unit or the subject, and the evening we're going to look at abdominal assessment. And for abdominal assessment, we need to see different things in relation to the techniques of assessment. There's noise on the background. I don't know whether I'm clear. So I was saying this evening we are going to continue with the health assessment as a course unit, and we are going to look at basically abdominal examination or abdominal assessment. So what do we need to do when we are examining our patients in relation to the abdominal assessment? So the introduction, basically we are saying that the order of assessment techniques for the abdominal assessment differs from other systems. And as we go along, we shall realize that we don't assess our patients, the abdominal sites or the abdominal region are the same way we assess the other areas of their bodies. And the reason is basically clear, as we say that abdominal assessment are the sequences by inspection, auscultation, percussion, and palpation. This is controversy to the rest of the assessment when you're doing in the other parts of the body, just because when you start to percuss and then palpate, you're going to alter the sound that you'd hear when you're doing the auscultation. So basically the change is because you're going to start with inspection, which is done by when you're doing any other part of the patient's body. Then you'll go ahead to auscultate, and then percussion and palpation. But if it was any other part of the body that you're assessing, not necessarily the abdominal region, you do start by inspecting, palpating, you percuss and auscultate. So the reason here is because palpation and percussion precede auscultation to prevent alteration of the auscultatory sounds. So the auscultatory sounds will alter in case you start by percussing and then palpating. So you first have to auscultate so that you can get the sounds very clearly before you go ahead to percuss and palpate. So what is the history that you're going to take from your patient in relation to abdominal assessment? So the health history that you're going to focus on basically is to conduct a comprehensive health history with a focus on abdominal aspects. So this is by identifying the risk factors for altered health through inquiries about: one, abdominal pain history. Ask your patient if he has been having any pain around the abdomen. Then also talk about indigestion. Indigestion is like the patient eats, but the food he takes in does not get digested. So you can also find out from your patient whether he has this experience. And then nausea, vomiting, constipation, and diarrhea. So when a patient has indigestion, sometimes they end up having also constipation. So when you're taking the history, you need to ask all these, whether your patient has those experiences, and you can be able to know what could be going on in the patient's abdomen, and you deal with it in relation to that. Then food allergies. You also have to find out from your patients if they have any food allergies, because sometimes it may precipitate to diarrhea, constipation, even nausea and vomiting. So you should find out from your clients if they have that kind of allergy in any type of food that they feed. Then also lactose intolerance. This one, there are patients who do not want to actually take in lactose. So this can be due to milk. When people take milk, some of them it irritates and they end up with diarrhea. So you can find out from your client whether he has that experience of lactose intolerance. Then appetite, food and fluid intake. Find out if your patient has a good appetite or he has lost his appetite. And then also the foods that he takes and the fluid intake, whether he's able to feed or is able to drink. The other one is the bowel and bladder elimination patterns. Find out from your patient if he's able to empty his bowel and the bladder, because it is very necessary. If a patient is feeding, the patient is drinking, this patient or this client needs to also empty the bowel and the bladder, because what goes in at a certain point has to come out. So this is very important for each and everyone who is healthy. And then the gastrointestinal and urinary tract disorders. Find out whether your patient has any gastrointestinal problems, whether he has either peptic ulcer and some other maybe conditions that may be able to tell you it has in relation to his gastrointestinal system. Then also the urinary tract disorders. They may tell you, I have frequent passing of urine, I feel maybe some discharge, and so forth. So all this can trigger to something else happening in your patient. So find out all this history and can help you to assess the health status of your patient. Then the outcome, identification and planning. So what do we have to look at in the outcome? You have to conduct assessment without patient anxiety or discomfort. So when you're talking to your patient, ensure that your patient is not anxious and your patient is comfortable, so that they can be able to open up and tell you exactly what is happening with them and why they have come. Then document the findings. Many times we get information from our patients, but we end up not documenting. But it's very key that we should always document whatever information that we pick from our clients, because at a certain point you may need that information and the client is not there and you cannot ask him at any moment. So it's good for you to document everything that you do and what you pick from your patient, so that you can use it as a reference, you can use it as an evidence, you can use it even in case of any illegal kind of issues. They may say how, when, and all that. So this can act as a defense to you, that this is the information the client gave me by himself and he used it for the management or he used it for any other purpose for the benefit of the patient. So also make appropriate referrals to healthcare professionals based on the nursing diagnosis. So we need to have a good outcome and we need to plan how to manage our patients. So when we need a good outcome and we have to plan very well on how to handle these patients, we always believe that even referral is a process or is one of the measures of managing our patients. So when you assess this patient and you're not able to help this patient, then do the referral system. Help this patient to go to the facility or to get a professionalist who is able to handle his condition. Don't stay with this patient, because you're going to predispose him to complications and even mortalities. So let's always make appropriate referrals early in time, so that these patients can reach to the health facilities, to the various professionals who are able to offer them the services. So I want us also to understand some of the special considerations. So in relation, they say general considerations. One of them is warm equipment to prevent patient chilling. So you're going to use a stethoscope basically for listening to the bowel sounds, and you very well know that the drum on the side of the diaphragm and so forth, you're going to use to put and to listen to auscultate. This patient is going to feel the chills. So make sure that you warm that part where you're going to use for listening to the bowel sounds. So when you use that, it will help you even the patient to be stable and the patient will be comfortable for you to take to listen to the bowel sounds. So even your hands should be warm. Let's not touch patients when our hands are cold, because this can also destabilize our patients and they get scared. They feel it is cold, they feel your hands are very cold to touch, they feel even the equipment we are using is cold. So we have to warm this before we put it in contact to our patients. Then infant and the child, they always get scared, they fear the health workers. So when they see you coming with the stethoscope, they see you moving closer to them, they get scared. So let's see how to handle the children. Let's see how we handle the infants. Sometimes we can just use tactics to convince them so that we can be able to examine them. Otherwise, they'll start crying, they start yelling, they become uncomfortable, and even the position for you to examine will not be easy for you to position them. So we have to put that into consideration. How are we going to approach these infants? How are we going to approach these children? And also, the way we examine the infants is different from the way we examine the adults. So we need to put that into consideration and to see that we get this right. So not you're going to inspect, you're going to auscultate, you're going to palpate, and you're going to percuss. So the other thing that is also key for the case of the infants is to look at the cord, the umbilical stump. Or if the cord has not fallen, how is that cord? Is it clean or it is showing signs of sepsis? Because it can predispose these children to neonatal sepsis, these newborns. So you have to examine the abdomen, put keen note on also the umbilical cord or the stump so that you can be able to identify the signs of infection and address them in time. Special considerations continue as this. You also have to expect large abdomen in infants. Their abdomen is actually large, but is broad when they are lying on their back. Then also you realize that it is more protruding than the adults. So that may not show that maybe this baby is having a problem, but in most cases it is normal for the children or for the infants who are just born. That is the normal shape of their abdomen, but should not again be very distended, or it should not be so prominent that there is a problem inside the abdomen. But when this baby is lying on his back, you realize this abdomen is broader. It's not like the way this for adults looks like. So for the older adults, you have to observe the decreased bowel sounds. And if there are decreased bowel sounds, then you should be able to think of something else, because the bowel sounds should not decrease. They should be in a normal um they should be always in a normal rate. They should be regular. And when you put the stethoscope to listen, you should be able actually to listen these bowel movements very clearly. So when you see that they are decreased, then you should be able to know or to understand that there is a problem. If a patient was operated and there are decreased bowel sounds, then you should also think of something going on in this patient's abdomen. Then also, in case the patient has been normal, there has not been any problem, even when he eats, he doesn't feel any constipation, but from nowhere he starts feeling any signs either of constipation, the bowel sounds are deteriorating or decreasing, then there can be a problem inside the bowel of this patient. So you should not take it for granted. You could also go ahead to do certain investigations, either abdominal ultrasound or abdominal x-ray, to rule out any kind of maybe it can be intestinal obstruction that could be trying to set into this patient's intestines. So we have to assess all this so that we can be able to manage our patients in time. Abdominal tone is also very important for you to listen. Then also fat accumulation. Some people have a lot of fat that even when you try to percuss, the sound does not come out very clearly. Even the bowel sounds do not come out very clearly. So the patients who come and they have a lot of fat, increased abdominal fat, their bowel sounds may be a bit decreased compared to the patient who is having a few or little fat. So the accumulation of fat also contributes to the lowering of the bowel sounds. So you should look at your patient's abdomen and assess. If he's a fat person, you cannot compare his bowel sounds to be the same sound like that one of a person who has little or low fats. So also that we have to put into considerations. So on evaluation, documentation, and nursing diagnosis, and when you're evaluating this patient, the patient participation in assessment is important. So you should not do your assessment alone and make your own judgment, but your patient has to also participate. You need to ask this patient a number of questions and he has to respond. Because if the patient does not respond, that means you're going to get a wrong information. You're going to use your own personal judgment, which may not be right. Then verbal understanding of the techniques. You should also have to understand these techniques. You should be able to know, when am I supposed to percuss, when am I supposed to auscultate, and when I percuss, which ones are the normal sounds when on percussion. If I hear this sound, is it normal? It is not normal. So you should be able to know the normal sound when you're percussing, and the normal sound when you're, I mean the abnormal sound when you're percussing, or also on auscultation. How should the normal bowel sounds sound, and how should the ones that are not normal sound? So there you can be able to differentiate whether your patient has a normal sound of the bowels or it has abnormal sound of the bowels. So completion without anxiety. Make sure that you complete assessing this patient without anxiety, because anxiety can destabilize and also can cause wrong results in your assessment. Then documented findings. Make sure that you document your findings after you have carried out your assessment, so that you can use it for reference in case of anything. Then appropriate referrals should be made so that these patients can access treatment and management in time. So when you know that you're not able to handle this patient, don't keep the clients with you, but refer them to access the expected management so that the lives can be saved. Documentation guidelines. So you have to record assessment techniques and specific findings. So if you've done inspection, you have to give your assessment according to what you have seen when you're inspecting the patient's abdomen. So you have to give specific findings for the specific techniques. So the patient has abdominal pain, and you have to record that in auscultation the bowel sounds were decreased or the bowel sounds were normal. Then also in percussion, what did you hear? What sound? In palpation, what did you feel as you're palpating? Was there any enlargement of the internal organs? And you have to note them in different, you have to note them in sorry, my screen has gone off. My screen has gone off. Let me reshare. I think my network is a bit unstable. Let me see what could have gone wrong. Sorry about that. My screen. I'm trying to share, but I think I have a challenge with the network. It went off, the slides went off, and I saw like I'd left. But let me try to get back. Okay, let me look for the slide where we were. We had finished the special considerations. We had talked about documentation and we're in this slide where I was talking about evaluation, patient participation, participation is verbal understanding of the techniques is also very important before you start carrying out the assessment. Understanding of the techniques is also very important before you start carrying out the assessment. Findings. So you have to note the skin, the color, the symmetry, the disc. So we need to put on our protectives so that we can be able to prevent a cross infection from us to the patient and from the patient to us. Then also prevent microorganism spread, and then PPEs. The PPE is based on transmission precautions. We should also be able to look at that. Jesus Christ, what is my slides are keeping on disappearing. I don't know what could be the problem. I try to share. I present for a short time, they disappear. I come back, I present for a short time, they disappear. I don't know whether it is the network issue.
Today you challenged with the internet.
I think there is a problem with my network.
Today you challenged with the internet.
I think so. I even don't know now. It has interfered
Maybe
with
we
me
make it
several
tomorrow.
times.
What do you think?
Yes,
We make it tomorrow?
maybe because I'm seeing it is so challenging. We can just leave this, then tomorrow we just start afresh.
Okay.
All right. Okay, good night.
Alright, please. Omukazi akomyewo kuva ku ssomero. Kasifa akomyewo. Mumpe. Yeebase. Kasifa. Yeebase dda. Mulamu wakuwaayiriza agambye weebase. Lwaki mwagobye ekyemu ku ssomero? So yabasiibudde. Yabagambye ati. Yabagambye atya ng'agenda? Ate yabasiibudde ate tewali. Yagala kuba otya? Basomesa ki abo abagambye? Gwe musomesa ki yakugambye nga ggwe? Kyogamba omusomesa yagambye tomumanyi erinnya? Obadde okyanyumiza. Essimu n'ogiggyako.